Welcome everyone again to the University of New Mexico Law Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This is a series run by the Division of Forensic Behavioral Sciences of University of New Mexico's Department of Psychiatry and Behavioral Sciences in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perillo, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenters, the Q&A box is your friend there. Make sure you enter your questions in the Q&A box. You can enter those anytime you feel comfortable. Just do know that we hold questions until the end, and it's often not possible for us to get to all of them. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly, so keep your eye on the chat box. If you are pursuing APA continuing education credits, you will again keep your eye on the chat box, but in the latter portions of the talk, there will be a link to complete your CEU survey. Make sure you bookmark that link if it's not working for you at the time or if you're not going to open it immediately. And make sure after you complete the survey, you save your certificate because we don't have access to certificates after the fact. If you missed last week's talk in the series, Dr. Carol Holden's thorough discussion of issues in juvenile violence risk assessment is now available on our YouTube channel. The recording for this week's talk should also be available on our YouTube page later this week, and the PowerPoint slides will be accessible for people that are registered for the series later in this week as well. As a heads up for next week's talk in the series, we have Dr. Bill Frankenstein, who will be discussing assessing substance abuse allegations in high-conflict family court cases. But circling back to this week, I'm really excited to introduce you to today's speakers, who'll be discussing contributions of non-clinical staff in brief intervention for suicidality for those that are involved in the juvenile legal system. We have Dr. Kathleen Kemp and Dr. Kaitlin Sheerin. Dr. Kathleen Kemp is an associate professor at Brown University, Warren Alpert Medical School, staff psychologist at Rhode Island Hospital Department of Child and Adolescent Psychiatry and Bradley Hasbro Children's Research Center, and the director of the Rhode Island Family Court Mental Health Clinic. She specializes in forensic mental health evaluations with adolescents in the juvenile legal system. Her clinical research focuses on suicide prevention and substance use intervention, as well as the dissemination and implementation of evidence-based treatment with youth involved in the legal system. She's been the PI, co-PI, and site PI on several university and National Institute of Health funded grants, and her current grant focuses on training community-based clinicians who serve youth involved in the legal system and suicide intervention. We also have Dr. Kaitlin Sheerin, who is an assistant professor at Brown University Warren Alpert Medical School and a research scientist with the Rhode Island Hospital Department of Child and Adolescent Psychiatry. Her clinical research focuses on two lines. One on developing, adapting, and evaluating behavioral health intervention and assessment approaches for youth involved in the legal system, and a second line of work that promotes equitable access to quality behavioral health care for those system-involved youth. So Dr. Kemp and Dr. Sheerin, on behalf of the University of New Mexico, we're very thrilled to have you joining us and thankful for you sharing your expertise with us today. I will go ahead and turn it over to you.
Great. I will go ahead and get us started. I'm going to share my screen since I have slides for you all. There we go. Okay. So Dr. Kemp and I are just so excited to talk with you all today about expanding the role of non-clinical staff, using a case example of implementing a brief intervention for suicidality in the juvenile legal system. Thanks so much for the kind introductions. Just to reiterate, we're both faculty in Brown University's medical school and through Rhode Island Hospital. I know that the issue of CEs was already raised, but please be watching the chat for further information about filling out those CE evaluations. Today, we do not have any conflict of interest to disclose, nor any relevant financial relationships to disclose. And the views that we're expressing today are our own and don't represent the University of New Mexico. So we have three learning objectives we're going to cover today. The first is describing task shifting, that is expanding the role of non-clinical staff for carefully selected brief interventions and its application to an intervention for suicidality in juvenile legal settings. The second is to explain implementation strategies and barriers to uptake of interventions for suicidality by non-clinical staff. And finally, to discuss future directions of brief intervention implementation by non-clinical staff in legal and other settings. Okay, so we also have a pretty packed agenda for today. We are first going to discuss task shifting, why we should do it, what our current services to needs gap looks like, Early examples of successful task shifting, steps of task shifting, including selecting the intervention, how to implement the intervention, and implementation outcomes. And finally, we'll conclude with lessons learned and considerations. Okay, so we have a services to needs gap for both adults and youth involved in our legal systems. So I want to talk a little first about where did it come from and how we can address it. So we live with two very hard truths right now. One of them is that youth in the juvenile legal system and adults in the criminal legal system experience much higher rates of mental health and substance use concerns than their peers in the community. However, they face inordinate barriers to accessing behavioral health services, such that most who need services don't receive them. And big problems like this are all multi-determined, and there are multiple factors associated with the services to needs gap. I'd also be remiss if we didn't talk about inequities in access that exist. It is already well known that Black, Hispanic, and other individuals of color make disproportionate contact with the legal system. However, it isn't just the legal system where inequities exist. We also know that Black, Hispanic, and other individuals of color also have difficulty accessing mental health services. So, for example, as depicted here in the graph you can see on your screen, Luna and colleagues published what I think is actually a really seminal study this year. That was a 16-year follow-up of the Northwestern Juvenile Project, which is a sample of formerly incarcerated youth. And at 16-year follow-up, less than 20% of all youth who needed services received them, which is a really striking number when you think about that in the context of that's just the number of services received, right? We're not even talking necessarily about evidence-based services here. So although we don't necessarily have good, fast, and hard numbers about how many youth might have received evidence-based services, we can imagine that it's less than 20%. The authors also found that there were ethno-racial inequities such that Black participants with any disorder were much less likely than non-Hispanic, white, and Hispanic participants to receive any services. Similarly, Spinney and colleagues in 2019 published a study showing that it's not just getting into services, but that very first step of referral where we also have issues where Black and Latinx individuals were just much less likely to be referred by juvenile justice staff to treatment than white individuals. So we know that these inequities exist, and I think for a long time we have really classically blamed individuals for not being able to get into services, and particularly mental health stigma. However, I would pose that with the amount of barriers that individuals currently face, we should ask ourselves, why would anyone be motivated to access services? So I put a few drivers of the services gap here on the screen, although there are many more. So one example, of course, is insurance, where people can't afford to pay for services. There's also structural racism and discrimination. So a study by Adams and colleagues used a mystery shopper method where a Black voice actress, Latina voice actress, and white voice actress all called over 200 community mental health agencies in Cook County, Illinois, posing as mothers requesting a mental health appointment for their traumatized child. Callers were only able to schedule an appointment in 17% of cases. However, I thought what was most striking was that Black and Latina callers were significantly less likely to be offered an appointment than white callers. So we also have structural racism and discrimination as a determinant of who accesses care in the system. There's also a lack of coordination between system staff and those in the mental health system. There may also be stigma against legally involved individuals, such as providers viewing them as being dangerous or having too much clinical need. And then finally, the issue that we will talk about today, which is the lack of available providers. So even when people have the desire to get into services, they can't access it. So the National Center for Health Workforce Analysis did a survey of how many community behavioral health providers we have. And the findings were really striking and really disappointing. More than half of the US population lives in a mental health professional shortage area. So for those of you in the audience who've ever tried to help a family member or friend get into services, You may have experienced the fact that it is really difficult to get an appointment. There are just not enough providers. And what I find to be even more concerning is that this shortage is really projected to worsen over the next decade and not get better. So it's really clear that we need to heighten our mental health workforce and get more folks into the mental health workforce. But we also have to do more than that because this is a big, big problem and we need a multi-pronged solution. So one way of addressing this issue is through task shifting. So task shifting is defined as having non-specialists deliver mental health interventions. So for those of you in the crowd who have your annual primary care visit every year, you may notice that you get a mental health screening. That is considered to be task shifting, and it's a classic example of it. Task shifting is also typically applied in low resource settings. So we think of primary care offices, we think of schools. But legal settings are also a low resource setting, often underfunded, understaffed, and the staff who do work there often have high workloads. Task shifting is also a systems and organizational level intervention. So I hinted at this earlier, but I want to be even more explicit. Our current inability to get folks into services is not an individual level issue. It's a systems and organizational level issue. And systems and organizational level issues require systems and organization level interventions. At the end of the day, there are just not enough individual interventions to make the problem, quote unquote, go away. So we know that task shifting has worked really well in other settings. So I'm going to go back to the example in primary care. So Leong and colleagues in 2021 published an umbrella review of task shifting in primary care. And what they found is that it was effective in several areas, including improving health outcomes for patients. So blood pressure, attendance at follow-up visits, their overall mental health and well-being. And it also had a systems level benefit of having a cost savings. They also highlighted several effective strategies that you can see here on the screen for implementing task shifting. I'm just going to call out a couple here that they especially highlighted as being really important. So one is a supportive organizational system. So if those at the top of the organizational structure don't support task shifting, then it has difficulty working. But when there is support, it really facilitates things. The other piece is financing, and there's two things to think about here. One is, how much is it going to cost to do task shifting? How much will it cost to train people in new tasks? The other piece, though, is also the cost savings that can be had due to task shifting. And then finally, training and competency. I'm sure we've all been in a place before. We've been given a new task at work and just been told to do it and learn how to do it on the fly. We know when that comes to task shifting that folks can't really implement task shifting that way. They need training and they need competency benchmarks. So there is promise for task shifting in legal settings. Legal system contact represents an opportunity to implement evidence-based brief interventions. So I alluded to before the fact that folks not only have trouble accessing any interventions, but very likely especially evidence-based interventions. We also know, especially for legally involved individuals, there's a lack of providers to provide brief interventions, so non-clinical staff may present an opportunity to provide those interventions. There's also an opportunity to provide better connection to ongoing services through doing these brief interventions. So the question arises of whether or not task shifting can be applied to brief interventions delivered by legal system staff. However, I think we should all be skeptics in the crowd. You know, when we do systems level interventions, there's a lot that can go wrong, so we need to do them thoughtfully. So a few questions that I think I really asked myself about task shifting really is there buy-in for task shifting? Does the system want to do it? Do the individuals who would be doing the task shifting want to do it? Is it feasible and acceptable to implement task shifting? Legal system staff are very, very busy. Would current policies allow for them to do it? And does the selected intervention fit the needs of the individual youth or adult involved in the system, the staff in the system, and the setting? If you can't make it fit all three needs, it's really hard to do task shifting. So given the promise and the potential pitfalls, we really wanted to talk through a fairly concrete case example today, which was having frontline juvenile diversion staff deliver a suicide-focused safety planning intervention. So first, what we need to think through is the scope of the problem, right? Task shifting is best applied to well-defined problems. So within the youth legal system, approximately 10 to 20% of youth have experienced past 3-month suicide ideation. Now, I want to compare that to youth in the community who experience the same rate of SI in their lifetime. So we do have a concerning problem here. Another way to think of this is through our data on completed suicides, which is especially concerning. So there was one study that came out several years ago showing that youth in the juvenile legal system were 5 times more likely to complete suicide than youth in the general population. So we definitely have a concerning problem here that we should do something about. So I want to talk a little bit about this, how the status quo works for youth in the legal system when it comes to suicidality. So the status quo is, a youth endorses suicide ideation, they get sent to the emergency department. After they get discharged home from the emergency department, they have poor treatment engagement and follow through with community treatment, and they continue to remain at high risk for suicidal behavior. So the status quo, frankly, just isn't working. Another way to think of this is through the Juvenile Justice Behavioral Health Services Cascade. So this was a model that was developed for substance use services, but certainly applies to mental health services more broadly in the juvenile legal system. So you can see here in the cascade that from screening to assessment, to identifying youth in need, to referring youth to treatment, to initiating treatment, becoming engaged in treatment, and continuing care, there's fall off at every point of the cliff, such that you only have 20% of youth remaining in care at the end of the day. So currently what we're doing isn't working and isn't working well, period. So I want to talk through early success that's been had in task shifting, specific to mental health and substance use screening. So we've seen task shifting have success in a variety of different contexts for youth, including primary care. Alpert has seen success. So for those who don't know, Alpert is screening, brief intervention, referral to treatment. It's a brief intervention for substance use that's been implemented well with both youth within and outside of the juvenile legal system. And we've also seen mental health and substance use screening be very well disseminated throughout the United States at juvenile detention facilities, youth on probation, youth at juvenile diversion. And in fact, in the state of Rhode Island, youth receive a mental health and substance use screening, including the MASI-2, at every point of contact that they make. So screening is very well disseminated and has been successfully done with non-clinical staff who work in the juvenile legal system. And I do want to emphasize the fact that asking is really, really important, especially when it comes to suicide risk. We need to be screening. There seems to have been this myth perpetuated over the years that when we ask about suicidality, that we might make someone suicidal or trigger them, when in fact it's the opposite. Asking about suicide is a way of preventing suicide acts. It does not increase risk. Qualitative work with youth has also spoken to the fact that teens actually want to be asked about suicide ideation. And in fact, some teams have indicated that they would like to be asked daily or each visit when they're meeting with a provider or in a program. So asking is really important. And it's a really, really important first step. We can't identify problems that are going on if we don't ask about them. And as we found too, it's not enough to disrupt the status quo of youth being sent to the emergency room. So we need to do something where we're intervening. So knowing all of this, we want to think systemically at each point of the legal process, how we identify and intervene with at-risk youth. The sequential intercept model really represents a good tool to help us organize how to do that. So the sequential intercept model is really designed to think about how we can divert folks from the legal system into behavioral health services across these various intercepts, that run the continuum of crisis lines, 911, initial detention, first court appearance, involvement in jails or specialty courts, being incarcerated, and then finally being placed on probation or parole. When we think about youth in the juvenile legal system, we thought that intercept too. So juvenile diversion was a really good point of focus for us because it represents a brief contact with the system. Most youth are under supervision at juvenile diversion for, up to 3 months, but usually far less than that. And it's also one of the first contacts a youth might make with the juvenile legal system. And given the low rates of treatment engagement, even among diverted youth, we wanted to test task shifting brief suicide intervention from clinical to non-clinical staff to help reduce suicidal and self-harm behaviors and increase connection to services. So we picked juvenile detention. So I should also mention as well too that diverted youth, sorry, not juvenile detention, diverted youth. I should also mention that diverted youth make up over half of our youth in the juvenile legal system. So it's just another reason why this intercept was a good point to try and test an intervention within. So when we think about a systems level intervention, there are several ways that we can test them, but one of them is through something called a type 2 hybrid effectiveness implementation trial. So effectiveness means we wanted to confirm that an evidence-based practice was still effective when implemented by juvenile legal staff with youth. And the implementation piece means that we wanted to know if the implementation of the evidence-based practice can be done effectively in a juvenile legal setting. Today, we're really actually going to be talking about the implementation piece of things and less so the effectiveness piece of things, which means that we need a quick crash course in implementation science. So I'm going to give you the briefest overview you may ever get on implementation science. But when we think of implementation science, the first thing we think of is taking the thing, right? So the practice or intervention or innovation that we want to take and implement within a system. So we need to identify something that we think might work. Then we want to identify whether the thing works through efficacy and effectiveness research. And then finally, on the implementation research piece of things, what we really think about is how to best help people and places do the thing. That is really at the heart of implementation research. So just want to give you another way to think about this. There are many dissemination implementation science models. However, the conceptual model of implementation research really gives a very strong framework in terms of how to think about these types of outcomes. So we want to identify the what. So what is the evidence-based intervention or empirically supported treatment that we want to implement? The how, so those are implementation strategies, right? How are we going to get people to do this? How are we going to get the intervention to the youth that need it? And then we think about implementation outcomes. So today we focus on a lot about feasibility. So can it be done? Fidelity, can it be done the way it's supposed to be done? Acceptability, do folks who are implementing this like doing it, want to continue doing it? And then sustainability and uptake. The idea with implementation science is that these implementation outcomes should hopefully lead to better services outcomes, as well as better health outcomes over time. And with that, I am going to pass it off to Dr. Kemp and stop my share here.
Thank you, Kaitlin. Can you see my slides? We're gonna hope.
All good.
Okay, thank you. So now let's focus on an example of task shifting. Now that Kaitlin has reviewed and the implementation concepts and implementation science. So in order to do that, we're gonna talk about considerations for selecting an intervention and the interviews that we conducted to influence the how the intervention was implemented. Then once implemented, we'll discuss the service level outcomes through staff uptake, fidelity, and system buy-in. So what was the evidence-based brief intervention and how did we select it? As Kaitlin mentioned, there was clear data that youth involved in the juvenile legal system were endorsing suicidal ideation, and they were still living in the community. Most were not engaged in treatment and did not meet hospital level of care. We know that treatment providers have long waiting lists, and as Kaitlin mentioned, treatment access and engagement was limited. So we wanted to select an intervention that could not only help support the youth and the family in the moment, but also ideally facilitate follow-through with treatment referrals once they left. So we needed to consider service level and organizational issues. It was really important to be aware of the limited availability of resources within our own system, whether it's in terms of funding, personnel, or support services. We also had to navigate competing priorities between rehabilitation, accountability, but also really the overall well-being of youth and families. We wanted cases to be approached with sensitivity and consideration for the diverse needs and circumstances involved. And then we all have challenges in coordination of care between legal, mental health, and substance use agencies. How do we work to address the barriers to coordination and consider whether they stem from logistical issues or differing priorities among agencies? And finally, we had to weigh confidentiality considerations. The goal was to strike a balance between safeguarding confidentiality while still facilitating the best possible outcomes for all the parties involved. The intervention also needed to have a clear rationale for non-clinical staff in order to demonstrate the importance and applicability to their work. In this case, we know from echo-momentary data that suicidal thoughts come and go throughout the day. Not only is there a lot of variability in suicidal thoughts, but this happens pretty quickly and frequently throughout the day. We also know that most youth think about suicidal behavior for an average of about 15 minutes before acting. So the rationale for the intervention was to help youth get through the times when the thoughts were most intense and to prevent the suicidal thoughts and behaviors from escalating. The intervention we chose was an adaptation of the safety plan. A safety plan is considered a best practice when someone endorses suicidal thoughts and behaviors, but does not replace longer-term treatment. So a coping plan, which is what we called our intervention, is a one-session CBT-based intervention that provides an immediate response and a resource for families. It has 3 primary goals. The first is to help the youth identify warning signs that indicate they want to pull out and use their safety plan. The second is to help youth develop a list of coping skills, strategies, supporters, and resources that they might have access to in the moment. And then finally, it facilitates a conversation around making the environment safe, which we know is incredibly important for suicide prevention. Here's an example of the coping plan that we ended up implementing. The coping plan walks the youth through those warning signs I mentioned, indicating when they should use the coping plan. It also identifies ways to distract themselves in the moment when they are alone, people and places that can distract them, and people and professionals they could ask for help or support. The coping plan then walks through the rationale for and ways of keeping the environment safe, and it ends with a focus on the future reasons for living and results in a 1-page tangible plan that we encourage the youth to share with their caregiver at the end of the session and enlist the caregiver's help in using the plan during a crisis. It also had standard language to reduce disclosures that are uncomfortable both for staff and for youth and families, or that might place the youth and family at risk of further legal involvement. For example, instead of asking if there is a firearm in the home, the plan assumes everyone has a firearm and encourages the staff to discuss the importance of gun safety and how to obtain resources such as free gun locks throughout the state. So now that we identified the brief intervention and the rationale for why we thought it fit in the setting, we really wanted to learn from staff about what they needed to implement the evidence-based intervention. For this purpose, we conducted pre-implementation interviews to learn about organizational readiness and inform those strategies to enhance the implementation process and improve sustainability. So we wanted to look at three main areas: acceptability, appropriateness, and feasibility. For acceptability, it's defined as the perception among staff that a given intervention or practice is agreeable and needed in their setting. An intervention perceived as acceptable is likely to also be perceived as a good fit and aligned with an organization's goals and values. Appropriateness is the perceived fit of the intervention, in this case, the coping plan intervention, within a system and setting. And the feasibility was particularly critical for determining the extent to which the system and the staff are ready to incorporate changes in their workday and perceive that they are able to do so successfully. And it was also really important to interview folks at different levels, both those who would be implementing the intervention as well as those who might support them. So perceived need. And again, this is the concept of, is the thing important and or relevant to the setting and staff? So specifically, we wanted to understand if diversion staff believed youth were at increased risk for suicide. Did diversion staff believe that they play a role in helping reduce suicide risk, thoughts, and behaviors? And if not, how should it be addressed? And what we learned from staff was that through their experience implementing mental health and substance use screening, that they were also expressing concern about the risk of youth for suicide in particular. And noticed youth were openly disclosing suicidal thoughts, sometimes for the very first time in their life. Regarding fit of the intervention, so again, is the thing reasonably appropriate to be implemented here in their setting? So we described the brief intervention and asked questions about their perceptions of implementing this type of intervention. Did the staff view their role and the role of the court as providing intervention services, and specifically suicide interventions with youth and families? Fit in terms of goals, content, length, and output were explored. So all staff identified promising positive attributes of a brief suicide intervention being implemented when a youth flags for suicide. Perhaps not surprisingly, all staff identified helping youth and keeping youth safe as the primary motivator to implementing coping plans, even when the diversion staff were not familiar with providing clinical interventions. We also asked open-ended questions to generate a diverse array of potential concerns. And the most common theme was the impact of additional time needed to complete the intervention, requiring families to remain at the court, then impacting potential plans for families to return to work, go to school, or facilitate childcare needs. So if the thing is needed and fits the environment, what do staff need to implement the thing and do it well? So in our case, if coping plans are used, we wanted to hear what staff would need to feel competent and comfortable in implementing the intervention if they are the ones providing it. What kind of resources would they need? We also wanted to understand their expectations of what might go well and where they might struggle. And we also wanted to hear their expectations about what they think youth and families will think of them providing an intervention. So most staff did feel comfortable with implementing a brief suicide intervention, but we saw a difference in comfort level between those who were newer to their positions and those who had more experience. Staff who were employed by the court for less than 3 years expressed confidence in their ability to learn and implement a brief intervention, where staff who had been employed for longer, more than 10 years, were much less confident and comfortable to implement a brief intervention. So overall, for perceived need and fit, most staff believe that youth involved in the legal system were at greater risk, and most court staff viewed the coping plan intervention as needed and acceptable within the court, with all staff describing benefits and many acknowledging the coping plan would be consistent with their role and objectives. But even with perceived need and fit, readiness for change was quite mixed. Staff identified several barriers, including staff comfort with delivering a suicide intervention, several logistical issues, office space, parking, childcare, as well as that time that it would take to deliver the intervention. But despite these barriers, people also offered their own solutions to the issues that they were raising. For example, For addressing staff comfort and willingness to participate in the implementation process, conversations with staff generated possible adaptations to the implementation process that might improve comfort. Staff promoted the development of clear and detailed step-by-step procedures, and they really sought an extended planning period with solicitation of their feedback on the policy and procedures that were being developed prior to implementation. There was universal agreement on the importance of an initial training and education. And there was almost complete agreement on the necessity of ongoing training and supervision, especially around quality management after implementation to continue to develop their skills and comfort level for conducting the intervention. So we used that information and went back to the literature to look for similarities and differences with effective training methods. And staff interviews coincided with 3 effective training components: didactics, supervision, and ongoing training or booster sessions. We know that didactics and supervision, though, are not enough to change behavior. Other components needed are role plays and self-assessment of fidelity to the intervention, which we also incorporated into our training. And several staff acknowledged that even with these implementation strategies, change would still be challenging and likely nonlinear. There was one comment suggesting that a mandatory top-down approach might even be the only way to gain adherence to our implementation procedures, which we are very much trying to avoid. So we took their concerns into consideration. We took into account their hesitation of some staff, the sensitive subject of suicide, and our concern around fidelity to the intervention. And we utilized a type of champion model for staff to self-nominate and engage in the training process. So we started with really a psychoeducation and promotion of the brief intervention and rationale, asked staff to self-nominate for the training, and then proceeded with training and supervision. We hope the trained staff would serve as champions or models for other staff in a non-threatening collegial manner to provide feedback and encouragement to participate through their own positive experiences. So, could the brief intervention be implemented and implemented well? In order to look at those implementation service outcomes, we focused on 3 main questions. So how many implemented the intervention, or what was the uptake of the intervention? How well was the intervention done, or was it done with fidelity? And was the intervention implemented with equity? So in 2019, we had our first training, and about half the office volunteered to participate in the original training. Out of that, 3 routinely implemented coping plans. So we were at about 25% of the office. And then COVID happened. And in the summer of 2023, we were then asked to implement another training. 10 staff were invited and 8 accepted, so about 80% of the office, and all are currently implementing coping plans. There was recently a request for another training that is going to be upcoming this summer, and we expect that that training will involve both the booster session for the staff who are already trained, as well as to offer training to new staff that have since come on board. An unintended consequence of our training is that agencies at other points along the sequential intercept model also asked for training and coping plans. So detention staff did implement coping plans with several modifications that were guided by the implementation team. And then probation staff also asked for training, but to our knowledge have not yet routinely implemented them. So could the intervention be implemented well? Before finishing each training, we reviewed the fidelity criteria with staff. This helped to define the expectations of a good coping plan and what we were looking for. As a fidelity check, coping plan sections were then rated on a 0 to 4 scale from doesn't meet the standard to meets the gold standard, with the exception of keeping the environment safe, which was rated as present or absent. For our purposes, looking across all coping plans, fidelity was met when 80% or more of the plans met criteria for the gold standard. So in the first 2 columns, recognizing warning signs and things youth can do to support themselves in the moment, staff met the gold standard in 83% and 84% of the coping plans respectively. For the next 2 columns, people and places that could distract me, and people I can ask for support. Staff approached fidelity with 79% and 77% of coping plans. Next, for keeping environments safe, staff included specific examples in 76% of the coping plans. And then finally, with my reasons to live, which was somewhat surprising to us, staff struggled a little bit more to elicit things the youth were looking forward to. So we added supervision and additional prompts within the coping plan itself. What am I looking forward to? What would I miss? Who would miss me? And that really helped ground my reasons to live, not only for staff, but for youth. And this process of the fidelity check and feedback also became a way to facilitate acknowledging the achievements that the staff had achieved and areas for improvement, as well as to gain feedback from staff about how it was going for them. So where do we go from here, and what did we learn in the process? So first, as Kaitlin mentioned, there's several important steps along the way. Defining the problem and having a clear rationale. We had a clear problem. Youth were endorsing suicidal ideation and had limited access to appropriate care. Next, it's really important to identify, can the problem be helped by a brief intervention? For us, there was literature suggesting that prior work in emergency rooms had success in offering an immediate resource and helping connect individuals to care, but that it would require an additional adaptation. So for us, identifying the intervention was identifying the safety plan and adapting it to our version of the coping plan to be successful with juvenile legal system involved youth. Next, assessing staff perspectives pre-implementation, really asking them about the fit, buy-in, and their readiness. And recognizing that even with buy-in, that readiness can really take time. And there are several organizational and cultural considerations that may impact the implementation process. So does the intervention fit with the organization mission and values? Are the right policies in place, or do there need to be additional policies and procedures developed? And does the system have a structure to support ongoing supervision and support staff, generally speaking? Do you have the right team, not only for implementation, but also for sustainment? Will the local team be taking over sustainment? If so, what does that team look like? Is it representative of their setting? And how will the training look the same or different from staff who are implementing the intervention? We know the implementation process may be anxiety-provoking and uncomfortable at first, stretching staff capacity in the moment. How will the sustainment team support staff initially and ongoing? It's also helpful to really think about, is there an incentive structure needed? Is helping the youth and family incentive enough, or are there other ways to build incentive for staff? And then regarding the right relationship, are you coming in as an outsider, or do you already have a pre-existing relationship? Spending time considering your relationship with the organization and system will have an impact on the implementation and sustainment efforts. But also, it's really important to consider whether the staff have or can have the right relationship with the receiver of the intervention. Prior research has shown better job satisfaction and empowerment among healthcare workers and better relationships with their patients with task shifting to address certain medical concerns. We were not able to measure those things in this particular project, but I think it's an area that's really interesting for future research. There are also a number of youth and family cultural considerations. Continuous data collection is really key to ensuring equity in access and quality. Helping systems to understand how to measure fidelity and build in data checks whenever possible will help provide a data loop to determine whether a service or intervention is implemented with equity. In particular, for our setting, are minoritized youth and families getting access in the same ways as white youth? Data collection can also help with double checking our assumption that interventions can do no harm. Interventions can always do harm, especially so for minoritized youth. Quality assurance mechanisms can help with these. The cultural context is also important to consider. In our case, that included translating the coping plan into Spanish and training Latinx staff to deliver the coping plan. Additionally, the coping plan incorporates family within the intervention, which is particularly important for minoritized communities. For a brief intervention, it's also important to consider whether it's strength-based. Does it promote a conversation that opens the door for future treatment in a non-judgmental manner? Brief interventions hopefully help the youth in the moment, but are also a foot in the door to encourage people to engage in longer-term treatment. And finally, there are also several considerations out there for those who may be implementing interventions in low resource settings in terms of our own expectations of what system change will look like and versus the reality. So sometimes when we enter settings, we enter with a mindset of, I am the expert. But in reality, everyone is an expert in their space. When asked, staff offered insights on possible barriers that needed consideration and also thoughtful solutions that ultimately improve the implementation and sustainment of coping plans. They were invested in clear policy and procedures and gave good feedback once those policy and procedures were created. People often think that change will be linear and happen rapidly, but the reality is that change occurs in fits and starts. Staff knew that even with their colleagues seeing the need and the intervention fitting, the implementation process would not be a pretty straight line. I particularly like a recent analogy I found about the lily pond when thinking about our expectations versus reality of system growth. The lily pond analogy asks, if a lily emerges on day 1 and doubles every day, completely covering the pond on the 30th day, what day will the pond be half covered? Most people are surprised that the answer is that half the pond will be covered on the 29th day. Expecting a system to change quickly can lead to unrealistic demands of growth and often slow, if not completely kill an innovation. And as we mentioned previously, even when you have buy-in and recognition of need, there are constantly new issues and important problems to solve. For us, that was COVID and the implementation of a remote workforce that happened in the middle of our project. But persistence, reinforcement, and using systems thinking and strategies are helpful tools to implementing task shifting for any brief intervention in low resource settings. And with that, thank you so much for joining us. Here's our reading list, and then which will be available to you, as well as the QR code for those who are interested, but also look in the chat for the link for the CEU survey.
Thank you so much, Kathleen and Kaitlin, for all of that very helpful information. Rather than sum it up, I'll say, the one comment that we have here is somebody saying, the sad thing about prevention research is that it's incredibly difficult to prove what didn't happen and why. I believe that you have undoubtedly saved young lives, even if it's hard to prove. This is incredibly important research, so thank you. I think that gets to the core of it here. We do have other questions from the audience. Of course, if you have any others for our presenters, make sure you enter them into the Q&A box there. The CEU links should be available there in the chat box, and Drs. Kemp and Dr. Sheerin have included their email addresses in the chat box if you have any other questions there that you would like to contact with them separately. The same person who commended you said that, impressed with this presentation. Government agencies are historically unable to move money from one budget silo to another. How do you encourage agencies to spend a nickel, even if it would save us a dime in some other agency's budget? Like, how do we actually get this investment here?
Yeah, I think that's a really great question. And the answer is, well, I don't know, but we do see with task shifting in particular that there is a cost savings, both on the systems end as well as the families that we serve. I think as Kaitlin mentioned before, youth and families are often referred to high-end costly services that clog up emergency rooms and cause other barriers to care for individuals who are seeking that level of care and need that level of care. But it is such a hard task to get people to shift funding from one particular resource to another. So it's a great question. If you can solve that, we think we would solve a lot of different problems around prevention.
Yeah, email them if you want to help save the world there. Yeah.
I was just going to echo that and also add on to that. A lot of these projects within these systems, initially are sort of run on a shoestring budget in a sense of demonstrating that efficacy and effectiveness is really important for being able to demonstrate that cost savings along the way. So oftentimes the answer is sort of this, again, hard truth of you do it with very little financing a lot at first.
Really important consideration for implementation here. Thank you for that. Somebody asked what your thoughts on mental health startup companies that are shifting care of clients to mental health coaches. Although technically task shifting does not seem like the coaches see clients with less pathology. Thoughts on this?
I will take a stab at that one. I think that doesn't quite meet the definition of task shifting, even if it's being sold that way. So task shifting should really be happening in existing infrastructures where you're taking someone who already has a job and a position, like juvenile legal system staff, and shifting their tasks to be doing, brief mental health interventions and screening, versus this is sort of adding a new system and a new structure. Truly, that's not, even if it's being sold that way, I wouldn't say that that's task shifting.
Certainly. Thank you for that. Yes. Any comments on potential liability issues related to task shifting or the projects that you've talked about here?
Yeah, I think that's really going to be setting specific. That was a question that came up in our setting. And what the conclusion was related to best efforts. If you are implementing something in order and not in a do no harm approach, that under the court setting that we implemented this, that staff would not be liable. And in fact, there was a question more about liability for screening and not doing anything, right? Not providing an intervention for somebody who may not have access to services. So the argument was that actually implementing this intervention would alleviate some liability if there was any there to begin with.
Fair enough. Thank you for that. Somebody asked, you mentioned community care, post-ER, and poor participation. They wanted to know if you've looked at intensive outpatient care referrals, say like afternoon, 3 days a week, transportation may be included.
I know that we have some data across several projects that just speak to the fact that there is low engagement in treatment, regardless of type of treatment. And so I think it speaks to, again, this is a multi-pronged issue. I really think that task shifting is just one potential solution. We need many more systems and structural level interventions. But one of the points I forgot to raise earlier is this: we have this notion of if we build it, they will come, which just hasn't been true and hasn't been the case. So, and also our brief interventions are definitely not meant to replace ongoing and needed services, but hopefully helping to build a bridge to those, in addition to ideas like providing transportation.
Yeah, I think a lot of this, it sounds like, comes back to accessibility and equitability issues. So yes, Dr. Kemp, Dr. Sheerin, thank you so much for a very thorough discussion on the really important work that you're doing here. I can tell it has inspired several others here, and they've included their email addresses if you want to discuss anything else with them further. That does wrap up this week's Law and Mental Health series. Next week, Dr. Bill Frankenstein will be discussing assessing substance use allegations in high conflict family court cases. We hope to see you then for another great discussion of issues and behavioral health in the law. Until next time, have a fantastic rest of the week. Thank you so much.